All right, guys, are we ready to start? So, yeah, the topic this morning is going to be on disorders of the eye. A little disclaimer, I am not an ophthalmologist, so please do not use this as your sole reference for studying. I tried to follow the content specifications as best that I could. So sit back and hold on tight. So we're going to start with alignment and movement disorders of the eye. So strabismus is another term for actual misalignment of the eyes. It occurs in about 4% of children less than 6 years of age, and it can result from amblyopia or vision loss. And actually, 30 to 40% of children with strabismus will eventually develop vision loss. So the restoration of proper alignment must occur at an early age of vision development to ensure proper binocular vision. Some terms in ophthalmology that I thought were important that I think we should know involve the prefix of the words, and the prefix actually will denote which direction the eyes deviate. So the prefix ESO refers to nasal deviation relative to the fixating eye. Exo is deviation temporally or outward. Hyper is deviation upward regardless of which eye is fixating. And then hypo is sometimes used to denote an eye that is deviated downward relative to a fixing eye. So here you can see some cat eyes with esotropia on the top, exotropia on the bottom, and hypertropia on, exotropia in the middle and hypertropia on the bottom. There you go. Some other terms, orthopia is a term that indicates ideal condition of exact ocular balance, implying that the eyes are made in a coordinated and aligned position. Heterophoria is a latent tendency for the eyes to deviate, typically under certain conditions as fatigue, illness, or stress. And then heterotropia is misalignment of the eyes that is constant due to control mechanisms of eye movement. The understanding of strabismus requires knowledge of two major principles that govern ocular mobility. And the first one is Hering's law, which is agonist muscles in both eyes receive equal innervation to ensure a coordinated binocular movement. Thus, when the right lateral rectus muscle is activated to abduct the right eye, the left medial rectus muscle is equally activated to adduct the left eye. And then a second law, the Sherrington's law of reciprocal innervation, is that agonist-antagonist muscles pairs within each eye receive reciprocal innervation. So thus, when the right medial rectus muscle contracts to adduct the right eye, its agonist, the right lateral rectus muscle, relaxes. Does everyone get that? Yeah. Okay. It took me a while, so yeah. So it's basically you're getting like a conjugate gaze. So there's two different laws that kind of govern that principle. Compared to strabismus, pseudostrabismus is the apparent esotropia or inward nasal deviation that typically occurs in children with a wide nasal bridge and or large epicanthal folds during the first few years of life. It's not a true strabismus, but rather an optical illusion in which the wide nasal bridge hides the nasal sclera, making the eye look esotropic, particularly when the child looks to the side, adducting one eye. So you can see in this picture that although the eyes appear misaligned, the light reflection is symmetrical in both eyes. So this child does not actually have a strabismus, but it's rather a pseudostrabismus. Okay, you can see here how the light looks pretty much symmetrical. So we as pediatricians can detect strabismus with several simple clinical tests. And as I said, it's very important to detect early to prevent the potential loss of visual acuity caused by disuse or misuse during the critical periods of visual development. So the first test is the cover-uncover test, and that's when a child looks at an object in the distance, typically about 6 meters away, and as the child fixates, the examiner covers one eye and watches for movement of the uncovered eye. And then after one eye is tested, the same procedure is repeated on the other eye. And you can see here that this is just a visual representation of a child being tested, the cover-uncover test. He doesn't look very happy, does he? Another test is the alternate cover test, and that's when the examiner rapidly covers and uncovers each eye, shifting back and forth one eye to another. And then if the child has ocular deviation, the eye rapidly moves as the cover is shifted to the other eye. Both the cover-uncover test and the alternate cover test should be performed at both distance and near fixation. And specifically, the cover-uncover test differentiates tropias or manifest deviations from latent or phorias. So moving on to nystagmus, or rhythmic oscillations of one or both eyes. They may be caused by an abnormality in one of the three basic mechanisms that regulate position and movement of the eyes, and that's fixation, conjugate gaze, or vestibular mechanisms. Congenital sensory nystagmus are generally associated with ocular abnormalities that lead to decreased visual acuity. And common disorders that lead to early onset nystagmus include albinism, aniridia, congenital cataracts, and macular lesions, as well as congenital optic atrophy. And congenital sensory nystagmus can occur as a dominant or X-linked inheritance pattern. Acquired nystagmuses require prompt and thorough evaluation, and these worrisome pathologic types are the gaze paretic or gaze evoked oscillations of cerebellar brainstem or cerebral disease. Moving on to conjunctivitis. The conjunctiva react to a wide range of bacterial and viral agents, as well as allergens, irritants, toxins, and systemic diseases. And therefore, conjunctivitis is very common in childhood and can be infectious or non-infectious. Ophthalmia neonatorum. This is a form of conjunctivitis that occurs in infants younger than 4 weeks of age. It is the most common eye disease of the newborn, and it has many different causal agents that vary greatly in their virulence and in their outcome. Ophthalmia neonatorium usually is acquired during vaginal delivery and reflects the sexually transmitted infections prevalent in the community. Rates of blindness have actually decreased drastically with the installation of silver nitrate solution that started in the end of the 19th century. Particularly, gonococcal ophthalmia neonatorium has an incidence of about 0.3 per 1,000 live births in the U.S., compared to Chlamydia trachomatis being the most common organism causing ophthalmia neonatorium with an incidence of 8.2 per 1,000 live births. Although the timing and the character of the signs are somewhat typical for each of these conditions, there's considerable overlap, and the physician should not rely solely on clinical findings to distinguish between the two. Regardless of its cause, ophthalmia neonatorum is characterized by redness and chemosis or swelling of the conjunctiva, edema of the eyelids, and discharge which may or may not be pregnant. Gonococcal conjunctivitis begins with mild inflammation and a serosanguinous discharge that becomes thick and purulent within the first 24 to 48 hours. There's marked edema and chemosis developing soon after, and if proper treatment is delayed, the infection can spread to the deeper layers of the conjunctiva and the cornea. And specific complications include corneal ulceration and perforation, um, iridocyclitis, and rarely panophthalmitis. So here's a picture of a child with gonococcal ophthalmia neonatorum. You can see the bilateral purulent discharge. Contrast that with conjunctivitis caused by chlamydia. It may vary from mild inflammation to severe swelling of the eyelids with copious purulent discharge, typically of later onset. And the process involves the tarsal conjunctiva, but rarely affecting the cornea. Gram stain of the purulent discharge should be performed and the material cultured if possible. If a viral cause is suspected, a swab should be submitted in tissue culture media for viral isolation. And in chlamydia conjunctivitis, the diagnosis is made by a gem-sustained epithelial cell scraped from the conjunctiva. Treatment for gonococcal ophthalmia should be initiated immediately with ceftriaxone 500 milligrams per kg per day for one dose, and the eyes should be irrigated copiously with saline. Neonatal conjunctivitis secondary to chlamydia is treated with oral erythromycin, 15 milligrams per kg per 24 hours, divided into 4 doses for 2 weeks. Neonatal conjunctivitis is a potentially blinding condition with associated systemic manifestations. Therefore, the prompt recognition and treatment is of paramount. So outside of the neonatal period, there are many other causes of conjunctivitis. Acute purulent conjunctivitis is characterized by generalized conjunctival hyperemia, edema, mucopurulent exudate, glued eyes, and varying degrees of pain and discomfort. It's usually the result of a bacterial infection, the most common being non-typable Haemophilus influenzae, which is also often associated with ipsilateral otitis media, but it can also be due to pneumococci, staphylococci, or streptococci. Sorry for the typo. And these forms of acute conjunctivitis respond well to warm compress and topical antibiotics. Contrast that with viral conjunctivitis, which is generally characterized by a watery discharge, and conjunctivitis from viruses results often from adenovirus, which is relatively common, and sometimes with corneal involvement as well as pharyngitis or pneumonia. And the clinical course of viral conjunctivitis is usually self-limited. Here you can see a picture of a more viral conjunctivitis type picture. Allergic conjunctivitis is often accompanied by intense itching, clear watery discharge, and conjunctival edema. It's often seasonal, and the treatment of this consists of cold compress and decongestant drops, which may provide symptomatic relief. And here you can see a picture of a child with allergic conjunctivitis. So moving on to preorbital cellulitis, or preseptal cellulitis, is inflammation of the lids and periorbital tissues without signs of true orbital involvement, such as propoptosis or limitation of eye movement. Preorbital cellulitis is a form of facial cellulitis, and it is pretty common in young children and can be caused by bacteria, trauma, an infected wound, or an abscess of the lid or the periorbital lesion. Patients typically present with eyelid swelling. The edema may be so intense as to make it difficult to evaluate the globe. And prior to the Hib vaccine, the most common cause of preseptal cellulitis was H. influenzae type B, but now group A streptococcus is a more common cause. And I have a couple pictures here. You can see this is the normal on the left, with marked edema and swelling of the eyelid on the right. And then another picture is of a little girl with swelling of her left eye. CT exam demonstrates edema of the lids and the surrounding subcutaneous tissue anterior to the orbital septum, and antibiotic therapy and careful monitoring for signs of sepsis and local progression are essential. And here is a CT. You can see that there's marked swelling of the eyelid and the subcutaneous tissue around the eye. Contrast that to orbital cellulitis, which is a condition involving inflammation of the tissues of the orbit with propoptosis, limitation of movement of the eye, edema of the conjunctiva or ecchymosis, and inflammation and swelling of the eyelids with potential decreased visual acuity. The mean age is about 7, but average ranges between 10 months and 18 years. And patients often feel ill with general symptoms of toxicity, fever, and leukocytosis. Orbital cellulitis is most often a result from direct extension or venous spread of infection from contiguous sites such as the lid, conjunctiva, globe, lacrimal gland, nasolacrimal sac, or more commonly the paranasal or ethmoid sinuses. Common pathogens include Staphylococcus species, including MRSA, as well as Streptococcus and Haemophilus species. And just a note, the most common cause of orbital cellulitis in children is a result from paranasal sinusitis. And here you can see a picture of a little boy with orbital cellulitis. So the potential for complications with orbital cellulitis is great. Vision loss can occur secondary to an increase in orbital pressure that causes retinal artery occlusion or optic neuritis. An extension of infection from the orbit into the cranial cavity can lead to cavernous sinus thrombosis or meningitis, as well as epidural or subdural empyema or brain abscesses. And a brain abscess is more likely to occur in the presence of an actual orbital abscess. So orbital cellulitis must be recognized promptly and treated aggressively. Hospitalization and systemic antibiotic therapy are usually indicated, and all patients require CT imaging of the orbit and of the surrounding CNS tissue to detect any subperiosteal abscess, orbital abscess, or intracranial extension. And if there's no evidence of improvement after initiation of antibiotics, or if there's signs of disease progression, then an orbital or subperiosteal abscess with subsequent need for drainage must be considered. And here you can see a CT that I found of orbital cellulitis, and you can see that there's much more edema and swelling that involves the globe and the actual nerve. Okay. So moving on, an external hordeolum or a stye is an infection of the eye involving the glands of Zeiss or mole. It's typically a small and superficial abscess that points at the lid margin and is usually caused by Staphylococcus aureus. And treatment is frequent warm compress and often the implication of topical antibiotics. So if you compare that to a chalazion, which is a granulomatous inflammation of the Momovian gland is characterized by a firm, non-tender nodule in the upper or the lower lid. The lesion tends to be chronic and lacks the acute inflammatory signs of a stye, and they may regress spontaneously, but may also require excision if they become large enough to distort vision or become cosmetically unappealing. And here you can kind of see a picture of the contrast between the chalazion and the stye. Okay. So moving on, congenital nasolacrimal duct obstruction, or dacrostenosis, is the most common disorder of the nasolacrimal duct system, occurring in about 6% of newborn infants. It's caused by a failure of canalization of the epithelial cells that form the nasolacrimal duct as it enters the nose. and signs of obstruction may be present at birth, although the condition may not become evident until normal tear production develops. So this is just the normal anatomy of the eye with the duct system. You can see that as the tears drain, it comes down this way. And here is a little baby with excess tearing. It's most often a result of nasolacrimal duct stenosis. So signs of obstruction include excessive tear lake, overflow of tears onto the eyelid and the cheek, and reflux of mucoid material that is produced in the lacrimal sac. Infants can develop an acute infection and inflammation of the nasolacrimal sac known as dacryocystitis, inflammation of the surrounding tissue, pericystitis, or rarely periorbital cellulitis. And with dacryocystitis, the sac area is swollen, red, and tender, and patients often will have systemic signs of infection such as fever and irritability. The primary treatment of uncomplicated nasolacrimal duct obstruction is a regimen of massage, usually 2 to 3 times daily, accompanied by cleansing of the eyelids with warm water. Topical antibiotics are used for the control of mucopurulent discharge. In most cases, resolve spontaneously, 95% before 1 year of age. But for those cases that don't resolve, the nasolacrimal duct may be probed, but this should be done by a trained pediatric ophthalmologist. But most often, cases will resolve before 1 year of age. Alright, so moving on to congenital ptosis. This is a result of localized dystrophy of the levator muscle, in which the striated muscle fibers are replaced with fibrous tissue. The condition may be unilateral or bilateral and can be transmitted as an autosomal dominant trait. So you can see here, this little boy has, or girl, has ptosis of the right eye. Because the levator is replaced by fibrous tissue, the lid does not move downward fully and downward gaze, thus giving the appearance of lid lag. There's one particular condition called Marcus-Gunn jaw winking ptosis that accounts for 5% of ptosis in children. And this is a syndrome where an abnormal synkinesis exists between the fifth and third cranial nerves, causing the eyelid to elevate with movement of the jaw. The wink is produced by chewing or sucking and may be more noticeable than the ptosis itself. So here is a little girl with the Marcus-Gunn phenomenon on the right side, with mild right upper eyelid ptosis, and then retraction triggered by chewing movements and lateral movements of the mandible. I don't think we'll ever see this though. So ptosis may be an isolated finding, or it may occur in association with other ocular or systemic disorders. Ocular disorders include mechanical ptosis secondary to lid tumors, congenital fibrosis syndrome, combined levator superior rectus maldevelopment, and congenital or acquired third nerve palsy. And then systemic disorders that may lead to ptosis include myasthenia gravis, muscular dystrophy, and botulism. You guys having fun? Right. So the next topic is glaucoma. The symptoms of infantile glaucoma include the classic triad of epiphora or tearing, photophobia, and blepharospasm or eyelid squeezing, and all of these can be attributed to corneal irritation. Signs of glaucoma include corneal edema, corneal and ocular enlargement, and conjunctival injection. Children with unilateral glaucoma generally present earlier because of the difference in the corneal size between the eyes, and that's much more noticeable. So here's a child with congenital glaucoma. All right. Trauma, intraocular hemorrhage, ocular inflammatory disease, and intraocular tumors are also important causes of glaucoma in the pediatric population, as well as systemic disorders that are associated with glaucoma include Sturge-Weber, neurofibromatosis, Lowe syndrome, Marfan's, congenital rubella, and a number of chromosomal syndromes. So, glaucoma versus cataracts. A cataract is any opacity of the lens. The incidence of infantile cataracts is approximately 2 to 13 per 10,000 live births. 60% are an isolated defect, whereas 22% are part of a syndrome, and the remainder are associated with unrelated birth defects. So here's a picture of a guy with cataract. Cataracts tend to be more common in low birth weight infants. For those babies that have a birth weight less than 2,500 grams, there's a 3 to 4-fold increase in the odds of developing an infantile cataract. So cataracts can also develop secondary to intraocular processes such as retinopathy of prematurity, persistent hyperplastic primary vitreous, retinal detachment, and retinitis pigmentosa, as well as uveitis. It also should be noted that a portion of cataracts in children are inherited, and the most common mode of inheritance for cataracts is autosomal dominant. So cataracts in infants and children can be a result of perinatal infections like toxoplasmosis, CMV, syphilis, rubella, and herpes. And it may also occur secondary to other perinatal infections, including measles, polio, influenza, and varicella zoster. So cataracts are primary manifestations of many metabolic diseases. Primary consideration in an infant with cataracts is the possibility of galactosemia. So congenital lens disease may also be seen in children of diabetic and pre-diabetic mothers. And hypoglycemia in neonates can be associated with the early development of cataracts. So lens opacities of various types may occur in association with chromosomal defects, like I said earlier, that include trisomies 13, 18, and 21, as well as Turner syndrome, and a number of deletion and duplication syndromes. Drugs, particularly corticosteroids, toxic agents, and trauma may also be the cause of the development of cataracts in the pediatric population. And I was going to go over retinoblastoma, but that was like one specific content specification, and I'm going to save that for the oncology people. So just be aware that cataracts can be one of the cardinal manifestations of retinoblastoma. I'm sorry? But we're going to save that for somebody else. You guys okay with that? All right. So moving on, and again, I'm sorry, these really aren't in any order because the specifications just kind of are all over the place. So the next topic is going to be on papilledema. This is a term used to describe swelling of the nerve head secondary to increased intracranial pressure. Clinical manifestations of papilledema include edematous blurring of the disc margins, fullness or elevation of the nerve head, partial or complete obliteration of the disc cup, generalized engorgement of the veins, and hemorrhages where the disc with disc and peripapillar exudase. So with papilledema, you can have transient obscuration of vision that can last seconds or longer and is associated with postural changes. Vision, however, is usually normal in acute papilledema. However, with sustained chronic papilledema or long-standing unrelieved increased ICP can lead to permanent nerve damage, atrophic changes of the discs, macular scarring, and impairment of vision. Alright, so I think this is one of the last topics, and then I have a chart that I wanted to show you guys. So retinopathy of prematurity we really only need to know the basic clinical manifestations or the clinical evaluations of retinopathy of prematurity in terms of the boards. So retinopathy of prematurity is a complex disease of the developing retinal vasculature that's often seen in premature infants. With that being said, prematurity is a major risk factor, along with oxygenation, respiratory distress or apnea, bradycardia, heart disease, infection, hypercarbia, anemia, and acidosis, which can also be contributory factors. I included this picture just showing that the zones of the retina there are different zones. We don't need to know much about this for the board specifically, but I thought I would include that for your visual pleasure. Guidelines for screening. This is what we do need to know. Is a birth weight less than 1,500 grams or a gestational age less than 32 weeks. But also, you would consider screening if the birth weight is between 1,500 to 2,000 grams or a gestational age greater than 32 weeks with an unstable course. And obviously, the screening is done by a trained pediatric ophthalmologist. So the timing for the first exam, you can see here on this chart that I made that most often if you're born between 22 and 27 weeks, you actually don't wait to screen until the baby is at 31 weeks post-menstrual age. Okay? And then any time that the baby is born after 27 weeks, you wait until they're 4 weeks of chronologic age before you screen them. So just remember up to 31 weeks if they're younger than 27 weeks gestation, and then after 27 weeks, you wait until they're at least 4 weeks gestation age before you screen them. And then I'm going to end with a chart that I found on painful erythematous eye. So just bear with me 1 second. Has this been helpful? You can say no. And most of the information that I got this from was from the abridged, like the short or the abridged version of Nelson's. So, yeah, the green one, yeah, but like not the big guy, like the electronic version. So, if there's any fault in my information, you know, you can blame Nelson. Okay. Can someone unplug it and plug it back in? All right. So this last thing that I'm going to show you guys is just a differential diagnosis for painful red eye. Okay. So this chart that I found, I'm not really sure where I found it, but I did, and maybe. But the differential diagnosis for painful red eye, if you see, this is actually a pretty good chart, I think. But they base it on different locations, particularly the orbit, any conditions of the lid and the lashes, and then the conjunctiva, the cornea, and then if you scroll down, the anterior chamber and the globe. So I mean, I don't know if it's worth going through because some of this stuff I already talked about, but you can see here that they basically, the important things are, is there or is there not any is the visual acuity affected, and then like clinical features plus or minus discharge, and then the treatment. So just I guess to go through, like an orbital fracture may or may not have complications of vision. There's often no discharge, but you're obviously going to have tenderness around the orbit as well as limitation of upward gaze, and any orbital fracture will require immediate referral to ophthalmologist. Yeah, yeah. So just know that if you suspect a fracture, you want to immediately refer the patient. We went over Stye and Clasian. Do you guys remember the difference? Okay, good. Remember, dacrocystitis can be a complication of nasolacrimal duct stenosis. Um, and that's when you, I didn't show a picture, but that's when you actually have like a nodule form at the side of the nasolacrimal duct. Orbital cellulitis. Okay, so this actually, remember, differentiating that from preorbital, you will have the potential for vision change, and then there's painful movements with painful eye movements with proptosis. But then if you compare that with periorbital cellulitis, there's no change in the vision, but you will have a swollen and red eye, but no pain with eye movements. All right, so then again, on back to conjunctivitis, bacterial conjunctivitis will usually have a mucopurulent discharge, whereas the viral conjunctivitis is more watery. All right. The cardinal feature of allergic conjunctivitis is like itchy eyes as well as like a runny nose. Yeah, we're unilateral. Hmm. May, or treat with just like symptomatic, maybe not necessarily antibiotic treatment. Um, so I didn't really talk about corneal abrasions, but with corneal abrasions, if you suspect a corneal abrasion, the best way to detect if there is an abrasion of the cornea, you guys know, is with the fluorescein dye. And then you can give them the, the particular drops to decrease the pain. I forget what they're called. Tetracaine, but it's important that you do not discharge them home because prolonged use of the tetracaine eye drops can affect the epithelialization of the cornea and affect their vision later on. So you can give it to them initially, but you never discharge them home with the tetracaine drops. All right. So if you suspect an ocular foreign body, there's probably going to be a history that includes trauma or hitting rocks or something. And it's really important to irrigate the irrigate the eye with water and high pressure to remove any foreign body, and then you want to refer if there's like prolonged symptoms. Um, Again, bacterial keratitis, which I didn't really talk about. You would see white spots on the cornea that stain with the fluorescein, and this requires immediate referral. Um, I don't know really if we would be able to distinguish bacterial and viral based on white and gray, but you can see here that if you do the fluorescent stain and you see spots, then you want to refer immediately. Okay. Um, and then again here, like I think someone mentioned it, like the hyphema. This is the blood. This is blood in the anterior chamber. Um, hypoion is pus in the anterior chamber. Okay, and each of these also require immediate referral. Um, and then we went over congenital glaucoma. You're going to have a mid-dilated pupil with a cloudy cornea, and this also requires referral. Yeah, that's about all I have. So